And this is going to be a little bit of a different speed, but Steve brought you kind of a little bit of an intro to this morning when we talk about the same kind of diagnostic ultrasound transducers that we're using for imaging. Can they have a therapeutic effect? And the answer appears to be yes, and in several areas that we're not really aware of. As you know, right now we've talked about LVO, the FDA-approved indication, that is very important. And we've talked about myocardial perfusion imaging. We haven't talked much about molecular imaging, which certainly can be done also with ultrasound. This is very potential where we could actually attach a specific ligand to a microbubble, and it will attach to early thrombus formation or to plaque, and allow us to visualize plaque and the components of plaque. But what we wanted to talk about here a little bit was the targeted applications of diagnostic high MI impulses. So we said when we talk about high MI, we talk about something about 1.0 mechanical index, or anything that may cause the bubbles to grow and collapse, either, as Steve said, in a stable fashion or in a little bit more of a inertial kind of fashion, which has several therapeutic applications that you'll be maybe a little bit surprised to see, and will definitely impact your future as sonographers and perhaps us as physicians. As we said, as we pointed out this morning, the ultrasound beam, when we transmit it into tissue of any kind, when the microbubbles are present, we, at a very low mechanical index, we're already getting these nonlinear responses that are shown in these big yellow sigmoid-looking curves here, and at the fundamental frequencies, he said, we're getting a lot of energy, even at mechanical indices of 0.18, while we're also getting harmonic energy. But we notice that after we give that high MI impulse, that the myocardium is cleared. In other words, yes, we get ultrasound contrast, but we're destroying the bubbles when we do that. Okay, why is that? Well, we know that we can look at their rate of replenishment at a very low MI and get to look at perfusion. But what we're going to focus on here is this high MI event. Okay, what is that doing? Because when we give it, even though we get replenishment, if we actually look at the events that occur with that high MI impulse, as we talked about, if we're using an IE33, we're giving, and we have it set to 1.0 MI, it's giving 0.5, 1.0, 0.5 alternating amplitude pulses with that flash. And you can dial in how many you want to give, 5, 10, 15, 20. But for EPIC, it's changed. Now it's giving 1.0, 1.0, 1.0 if you have a 1.0 MI flash setting. It's not alternating it. It's giving you a little bit more energy, okay? And typically it's low frequency, but it's very short pulse duration. All of our imaging that we do is in the 3 microsecond, maybe 4 microsecond when we're using a multi-pulse technique like the very low MI imaging. And as we're aware, the FDA is watching us now very closely, okay, to see, what's going to happen with that high MI impulse that we're using for diagnostic purposes. Well, if we actually could look at the bubbles, would that be helpful, right? If we could look and see what they were doing, that would give us some information about what is happening right down there at that little molecular level where you're hitting that ultrasound beam is coming in there. It's coming into the capillaries where we're imaging the heart. What's happening to the bubble? Well, we now can do that. We can't image them in the heart, what's happening to them, but we can certainly image them out in isolation. And we do know that as you get past about 0.4 MI, they're already breaking up. And they're breaking up into these little tinier microbubbles. And the process by which they do that, we can now image. Steve brought up this a little bit today. We now have optical cameras that can image at the same frequency that our ultrasound is transmitting. In other words, 6 megahertz optical frame rates, okay? So we can actually watch what the microbubble is doing in response to a high mechanical index impulse. Here's kind of like an M mode of a bubble, okay, in response to ultrasound beam coming in. You can see here it grows, and you can see it gets big, okay, literally. And remember, this is occurring over a period of microseconds, okay? This is that 2 or 3 microsecond long pulse. It grows when the ultrasound rarefaction wave comes in. and then it collapses when that positive wave goes back up again, just like ultrasound does. It's a sine wave. And in this whole process of it, depending on how high that energy is, or that peak negative pressure, which is what your mechanical index is, the bubble eventually, over that same time period, can collapse and create all these tiny little bubbles. Now, you may say, well, what's happening all around this area when a bubble grows like that and just suddenly greatly expands, okay? Well, I think you could probably look at it the equivalent of like a tsunami, okay? A little micro tsunami, okay? It's basically whatever's around it is going to collapse in the same way when the bubble's growing, so that creates shear. And that shear can be next to a thrombus or next to a cell, okay? Or wherever the bubble is, it's going to shear something, okay? And Lisa Villanueva now has, in Pittsburgh, has this camera, and she looked at a micro bubble here in response to a slightly longer than a diagnostic, but about an 8 microsecond pulse, very close to a diagnostic, and 1 megahertz pulse, 1 megahertz frequency. And simultaneously with watching the microbubble with her high frequency optical camera, she did real-time 3D confocal microscopy to look at a cell that was next to a bubble that was growing and collapsing. And again, as we said, when that's going through this is an 8 microsecond pulse, so you see it's getting at 1 megahertz, so there's 8 of these. You can see the bubble size here. This is a graph of the bubble size during that whole microsecond pulse. This is one pulse, okay, of ultrasound, okay, hitting a bubble. And then she looked at the cell that was right next to it. Here's the bubble, and this literally gone within microseconds. But then she examined over a period of seconds what happens to, in this case, propydium iodide, which typically only stays extracellular. It doesn't go inside the cell. Well, shortly after this event, which occurred next to an endothelial cell, and these are the cells that line our vasculature, you can see the propydium iodine it doesn't start to take up color until it gets inside the cell. It doesn't change color. Once it gets inside the cell, it starts to change color. So we start seeing propydium iodide here filling inside the cell. So as Steve pointed out today, a pore has formed, okay, that over a period of about 70 seconds becomes fairly intense, starts to concentrate in the nucleus of the cell. And if you look at calcium released with another stain, a calcium type stain, you can see all the calcium comes out of the cell and becomes extracellular. By 200 seconds, the whole process is over, okay? So you've created a small pore. Then she looked at all the surrounding cells, okay? You think, well, what does one bubble event occur? Does it affect just that cell that's next to it? No, it tends to affect all the cells around it as well, okay? In other words, here's a group of cells. The bubble event occurred right here, the little growth and collapse that I showed you. Well, that created, as you can see here, when she imaged this with the confocal microscopy where we have better staining, higher resolution, you can see the hole form here in the cell. See? That's now 1.94 minutes after this little microsecond event here, okay? One 8 microsecond event, about 1.9 minutes later, causes this hole to form in the cell, okay? Then the hole in the cell, just like Steve talked about today, begins to close off pretty rapidly, but you see a little escape of the propydium iodine extracellularly into the nucleus, and then it starts to close. But look what happens to all the intercellular junctions. All around, we see holes start to form between the cells that persist here 28 to 30 minutes later. We still see these gaps between the cells. So this 1 microsecond event caused a whole series of events in the cellular layer and the endothelial cell layers here that tell us why we get such enhanced permeability from these high mechanical index events. So that high mechanical index impulse we were talking about, that's great for LVO, that's great for perfusion, also has an effect on endothelial cells. I'll show you in a moment what it has an effect on thrombus. But this altered permeability has some implications. One is that whenever a cell is exposed to shear, it releases nitric oxide. Okay? And nitric oxide is a potent vasodilator. And Jonathan Lindner, this is some work from Todd Belchek, who's a sonographer that worked with Jonathan Lindner, looked at myocardial blood flow or microvascular blood flow in an ischemic hindlimb model. Okay, in other words, they made the limb ischemic by ligating the iliac artery, which is the major branch supplying the limb. So that skeletal muscle had no blood flow. You see here, here's a high MI impulse, and they gave the microbubbles first as a diagnostic imaging technique to show you that. Look at this. So after a high MI impulse here, 1 second, 2 seconds, 3 seconds, 4 seconds, you can see very little replenishment. Okay, because the iliac, the main artery supply to this muscle is cut off. Okay. Now, apply just some high MI impulses for a while. Cause those cavitation events to occur, growth, collapse, alterations in cell permeability. That shear over time, when it was applied for just 10 minutes, using a high MI diagnostic impulses, then they went and looked at the blood flow again with this replenishment curve. Look at what happened. Dramatic increase in myocardial blood flow. Remember, this leg has no blood supply, okay, from the main iliac artery, but it dramatically increased the collateral flow to this skeletal muscle, such that now it's got normal perfusion again. In fact, when he compared it to the contralateral normal perfused side, this had better perfusion in it than the side that didn't even have that had normal blood flow to it. So these high MI impulses were creating nitric oxide release. This is where they actually measured the nitric oxide release in response to 10 minutes of ultrasound applied here, intermittent high mechanical index impulses applied during a microbubble infusion. And this is a commercially available microbubble, okay? Or actually they might have made one on their site that looked very much like a fluorocarbon containing microbubble. But look what happened. After 10 minutes of applying this, the nitric oxide level went up, but it stayed up even after they stopped the ultrasound. So they were able to produce a sustained increase in nitric oxide. And they further investigated to see, where is that effect at? Is it just at the plane where we're imaging? Here's that a long axis view of that muscle in the leg. What are the muscles in the legs? Gracilis and bicep. I forgot my anatomy here. All the leg muscles, okay? The quadriceps, right? Quadriceps. So this is your mouse quadricep here, okay? So you can see what happened in the control here. You can see very little change, okay? But when they applied the high mechanical index impulses, remember this, there's no artery supply proximal to this. When they applied the high MI impulses, not only did they see an increase in blood flow with this maximum intensity projection image here, but downstream from the high MI impulses, they also saw increases in blood flow, as you see by all these projections of tiny little blood vessels being filled with contrast here. In other words, they have blood flow again after a 10-minute application of ultrasound just in this plane right here that I'm outlining with the arrow. So it increased downstream flow, and they examined to see how much of that is ATP mediated. Well, a lot of it was ATP mediated. In other words, we get a dramatic increase in ATP release from the endothelial cells, from the red blood cells, from these high MI impulses, that results in a sustained increase in blood flow. Here they used a photon flux. It's something called a luciferase assay that actually looks at blood flow or ATP production. And you can see shortly after the ultrasound application, you see a very nice increase in ATP production in this ultrasound insonified area here that persisted for 24 hours, okay, after the high mechanical index, 10-minute high mechanical index application. So you see, there's a potential there, okay? And they looked at it in sickle cell patients. They then looked at 12 patients with sickle cell anemia, okay? These are 18-year-old kids that have sickle cell disease. They're not in crisis at the time of this study. But because I'm so poor at anatomy, I had to draw this picture here to see. They looked at something called the flexor digitorum superficialis, okay? I forgot where this muscle is, but it's actually in the forearm, okay? And they looked in these patients. They gave the high mechanical index diagnostic impulses over a period of time and then used the microbubble diagnostically after using it therapeutically. Okay, we call this theranostic ultrasound, okay, because it has both a therapeutic effect and a diagnostic effect. But you can see after 10 to 15 minutes of applying these high mechanical index impulses, the blood flow, this is now seconds after the high MI impulse, look at how it changed. Here you can see there was relatively what we'd probably call normal perfusion. These patients weren't in crisis at the time, but look how it improved the blood flow to their forearm by applying these high MI impulses. very rapid replenishment. Most of it was in this replenishment right after the high mechanical index impulse, which is, we said today, reflects the red blood cell velocity. And that's what was really changing with these high MI impulses. Now, I told you about Shelby Cuddy, our pediatric cardiologist, okay? He was very interested in what potential this would have for catheter-induced spasm, okay? Because in pediatrics, catheter-induced spasm is a major problem. Anytime they try to cannulate a vessel in spasms, it can be sitting there like this. In other words, this is the femoral artery here in a pig model that we created. We give it and pigs are a lot like kids, okay? You just hit them a little bit with a cannula, and look at how it spasms. Look at how this vessel spasms. All the way from here, all the way to here. Look at that. It becomes like a thin versus. So you can imagine if this happens in a kid, they can't cannulate that vessel for hours, okay? A kid that needs a heart catheterization, okay? So the question is, he thought, well, if I apply those high mechanical index impulses over this site during a microbubble infusion, might that improve this vessel to allow me to cannulate it? Well, look what happened. He gave 10 minutes of diagnostic high MI impulses to this thin, virtually occluded, spasmed vessel, and within 10 minutes we already had a fairly, even by angiography, a much better looking vessel. And compared to control, significantly better, okay, just doing nothing and was waiting for the spasm to resolve. Such that the percent diameter stenosis went down to 50% from 80% by applying just these high mechanical index diagnostic high MI impulses. So you can see the nitric oxide, and this was all reversed if we used something that inhibited nitric oxide, as you can see here. Totally reversed that effect. It was all nitric oxide mediated shear. Now, these high mechanical index impulses were causing, by increasing the nitric oxide, the high mechanical index impulses were causing the nitric oxide release that was reversing the vasoconstriction. So there's application there. Others have used these same microbubbles and the high mechanical index impulses to target the delivery of some kind of payload drug. Steve talked again about this a little bit today, using something co-administered either with Definity, for example, a plasmid that contains a specific gene, or getting a charge on the microbubble, and you can easily do this. You can change the charge on the surface of the microbubble to a little bit more positively charged, so that these, what we call cationic microbubbles, now will avidly adhere DNA and even confer some protection from DNases in our bloodstream, because they hide inside these little positively charged little crevices, and it confers them protection from DNases that are circulating in our bloodstream. And then you can apply a high MI impulse to break up the microbubble at the site you want to deliver it, and concentrate the delivery of whatever agent you want to have at the site. And Paul Grayburn said, well, could I do that to reverse adriamycin cardiotoxicity? We're all familiar with that. We're all echo people and cardiologists in here. We dread the thought of what adriamycin does to the heart, but our oncologists want to use, they claim if I could just use a high enough dose, I could pretty much treat any kind of breast cancer or any kind of cancer. I just can't use a whole lot because the cardiotoxicity. So Paul Grayburn has developed a glucagon-like peptide. Now, we all know what glucagon-like peptides are. We're thinking liraglutide, our agent we use for diabetes, right? Well, if you give that same DNA that produces the glucagon-like peptide simultaneously with adriamycin in this rat model, he reversed the cardiotoxicity produced by adriamycin. And he gave it both at the same time he gave adriamycin, as well as 7 days after adriamycin. And both were able to, in this, you can see that's E and F here in this picture here. Here's what adriamycin does to the heart literally after a couple of doses in the rat. You see it basically turns it into a thinned, and if you're looking at its contractility, very hypocontractile ventricle. Now, if he gave adriamycin either simultaneously or 7 days after adriamycin, you can see they reversed this. The wall thickened, the walls no longer became thinned, and this fibrosis that tended to occur as a consequence of adriamycin cardiotoxicity was reversed by giving this GLP, or glucagon-like peptide, with a plasmid attached to a cationic microbubble. And by doing that, they could give much higher doses of adriamycin for the tumor without inducing the cardiotoxicity. In fact, what they observed in these, when he gave it 7 days after the adriamycin cardiotoxicity, they saw these cells the myocytes de-differentiate back to an embryonic form so that they could form all the different cells that compose the architecture of the myocardium. This was there's FOX1, which is a protein that seems to be responsible for adriamycin cardiotoxicity, as well as diabetic cardiomyopathy, as well as ischemic cardiomyopathy plays a role. They were able, by administering the glucagon-like peptide bound to a plasmid in the presence of the microbubbles, to force that FOX1 out of the nucleus, and that was the mechanism that we seem to be responsible for reversing this cardiomyopathy. So it's amazing work that they're working on now in larger animal models, demonstrating this targeted delivery technique where that high MI impulse is basically used to destroy the bubble at that site to target its delivery of a gene that then could be used potentially for adriamycin cardiotoxicity. Others have used this in peripheral vascular disease. This is some work of Howard Leong Poi in Toronto. He showed that by giving a VEGF, which is a vascular endothelial growth factor gene, with cationic microbubbles and targeting them to the limb of an ischemic hind limb model, again in a mouse model, they could cause the vasculature to return. This was what happened if you left them with an occluded iliac artery over 28 days. Basically, the microvessels are very small in number in this ischemic limb, but if you deliver a VEGF targeted to a cationic microbubble in the presence of high intermittent, high mechanical index impulses, you get the equivalent effect here of ultrasound-mediated VEGF delivery than if you gave it as an IM injection, right, directly into the muscle, because it covered a better part of the vasculature than an IM injection and resulted in better microvascular blood flow. Now, as Steve pointed out earlier, what if we just co-administered something with DEFINITY, as it is now? I told you those previous studies were with cationic microbubbles. Fuji's group did do that. They looked at an LAD infarction model. Okay, so now we're coming home, we're coming back to the heart, and we're looking at what happens in the post-infarction patient. Well, we know that after an LAD infarct, we remodel, right? We start to get heart failure, we start to get lower EF. Our walls start to thin. In this rat model, 7 days post-LAD ligation, in other words, they created an infarct, let that infarct get almost to the point of causing a scar. Then they gave IV plasmids that had stem cell homing factors on them, administered them with DEFINITY, and gave it 1, 3, or even 6 times. Just co-administered these agents. They didn't try to do any special change in the formulation of the microbubble. And then gave an intermittent high mechanical index impulse from a Siemens transducer, the 15L7, in other words, it was 7 megahertz high MI impulses. And then at 24 days later, looked at what the effect of either repeated delivery of these plasmids, like 1, 3, and 6 days, or just one treatment, what was the effect of that? You can see here that over the scar size, here, if they repeated it 6 times following over a 28-day period, the scar size was reduced from about 40% of the ventricle down to about 25% of the ventricle. The infarct wall thickness, the walls did not thin when they co-administered this agent. And the ejection fraction went from about 38%, you can see here in the control group, to about 50% in the repeated treatment group. Again, this was just co-administering with DEFINITY and giving those high MI impulses at the heart when the bubbles arrived, and then using the replenishment to see when they should apply another high MI impulse. In other words, they were using it when it was optimally number of microbubbles present within the imaging field. And they could reverse some of the effects of scarring just by using a stem cell homing factor. And they found that these stem cell homing factors did increase the concentrations of the stem cells within, or the embryonic cells within the myocardium. This was just using homing factors and endogenous stem cells. And I told you about the cardiotoxicity. So how does this relate then to possibly going to human studies? Well, as we said, one of the first things we wanted to do was see what's the potential for this to augment sonothrombolysis. In other words, augment thrombus dissolution in the early setting of a myocardial infarction. The pig model was a very nice model for us to look at in Nebraska because of our excess number of pigs. And with an LAD infarct, this is someone who survived an infarction, but you can see what happens when we give the pig a 15% lard diet for about like 60 days after a balloon injury of the LAD. This is similar to what hypertension and a high-fat pizza diet will do over a period of just 45 days. If you go back in there and inject some of the pig's own arterial blood, it immediately clots off that LAD. Okay. And they get something like this by contrast echo. This is before a high MI impulse, so this is a severe microvascular obstruction. Okay. Now, what was interesting in our first trials with this, we said, well, what happens with just repeatedly applying high MI impulses? We did that for 30 minutes. And look what happened here to the size of that plateau defect. It started to clear up. Here's what it looked like right before treatment, and here's what it looked like 30 minutes later. And a lot of this was occurring without epicardial recanalization. Sometimes it was occurring with it, but it was also occurring without it. Okay. In other words, we were doing the same thing that we saw Belchik's study do in the ischemic hind limb, that in the absence of even upstream recanalization, we were seeing improved blood flow. This mimics some of the work Bob Siegel had already seen many years ago with just when he put a low-frequency probe right over the heart in an open chest model and showed that you could increase the blood flow to the heart muscle with just low-frequency ultrasound. Well, unfortunately, with the transthoracic imaging, that's not really possible unless you have microbubbles present. Microbubbles lower the cavitation threshold. We're able to induce that inertial cavitation, and this seems to be a consequence of it, is that a nitric oxide-mediated increase in myocardial blood flow is occurring. And we looked at the ST segments. We compared full-dose TPA, which over 30 minutes really did nothing to the ST segments. Look what the ST segments, for those of you cardiologists in the room, you can see near complete resolution of the ST segments, applying these high mechanical index impulses. And the epicardial recanalization rates with that 30-minute delivery of intermittent high mechanical index impulses, although not what you would get with PCI, but they were definitely increasing with a short pulse duration shown in yellow here compared to TPA, or a longer pulse duration impulse, high MI impulse, during when you saw the microbubbles replenish the region. If you applied that, we even had even better epicardial recanalization rates. So we were getting both microvascular and epicardial recanalization. So that prompted what we had the discussion on this morning, that we went to the FDA and said, well, could we try this in humans? And they said, well, no, you need to now, that means you want an investigational device exemption. So that stalled things here in our own country to go to US of A. But Brazil, my colleague Wilson Matthias and Gianni Tsutsui, they applied to the Brazilian government and they approved it. Okay. They saw the potential. Okay. So we worked with them. Steve Spend came down to even to help some. In Sao Paulo, we were able to complete the first 100 patient trial looking at the effect of these intermittent high MI impulses applied to the myocardium after the patient arrived in the emergency department, because all we had available to us at the beginning of this study in 2014 were the high MI impulses on an IE33. So we couldn't take that in the ambulance, but we certainly could get it to them when they got to the emergency room. And so what we did is we took the patients that came in from 7 a.m. to 7 p.m. Because that's when we had a fellow available, okay, to apply the high MI impulses, apical 4, apical 2, apical 3, just aiming at the microvasculature here. Nothing about trying to aim at a coronary artery. Just aim it at the microvasculature, we said, because we knew that's where we were getting the beneficial effects. Even upstream, we were getting beneficial effects. And eventually we got to 303 patients that were, and we were just looking at first-time STEMIs, first-time ST segment elevation myocardial infarctions. 100 arrived in within that window of period of 7 a.m. to 7 p.m. on weekdays. 203 arrived on weekends or after hours, but they served as a reference group because we were looking at initial epicardial recanalization rates by the time they got to the cath lab. In other words, as you know, that's with emergent cath lab is the priority here to get the vessel open via stenting, and looked at what was infarct size. So we looked at the ST segment resolution, how much ST segment resolution occurred. We looked at the initial epicardial recanalization rates to see how many would have TIMI 2 or TIMI 3 flow, in other words, good flow in the infarct vessel by the time they got to the cath lab. Would we be effective at improving that? And then at 72 hours, we looked at MRI to determine what's the infarct size. In other words, a complete independent analysis of what was the infarct size that they were left with after this supplemental treatment with intermittent targeted high mechanical index impulses. And we also looked at microvascular flow by echo. In other words, how much with just intermittent, one diagnostic high MI impulse in the control group versus the repeated high MI impulses, of course, that we gave in the treatment group. The control group just had low MI imaging, except for just that one period of time where we looked at to see what their replenishment was before and after therapy, so we could look at what their microvascular obstruction was. So they got a couple high MI impulses, but nothing like the treatment group. The treatment group got repeated high MI impulses, like Steve said today, at least 15 high MI impulses in the 4-chamber, 2-chamber, and 3-chamber views. And as you can see here, these patients were well matched in terms of age, gender, weight, and pretty much all the risk factors. Door to balloon times, that was one of the concerns people had. Would this addition of ultrasound when the patient arrived to the cath lab, would that have an impact on the time the patient got to the cath lab? As you can see here, we're not affected. The fellows were very good. They basically took that machine and followed the patient wherever they went. This was the initial angiographic recanalization rate. So for the first time in humans, we see that we were able to get almost a 50% angiographic recanalization rate by the time they got to the cath lab. The spontaneous rate for that, for those of you in the control group and in the reference group, was about 20%, and that's about what's described in the literature. So for the first time, we're showing that we're getting even just by, and we were not aiming at the coronary arteries here, we were aiming at the microvasculature. But upstream, this is having an effect. This is the first time that that's been shown. Then you look at ST segment resolution. 50% of the patients, by the time they got to the cath lab, had ST segment resolution already when they were randomized to the intermittent high MI impulses, versus the control group that had low MI imaging only 4% had ST segment resolution. After the PCI, you might think, well, gosh, shouldn't all the ST segments come down? Only 32% of them came down in the treatment group that just had PCI alone without high MI impulses. Well, 67%, or that's 87 or 67% of them had ST segment resolution by the high MI impulses plus PCI. Troponin levels were significantly higher in the low MI only group as opposed to the group that got high MI impulses, as were CPK-MB fractions. And this is what happened, we saw frequently, was that initially you start out with this huge microvascular obstruction. See it all along here. Look at this territory, similar to images that we just saw in the previous presentation where you have this huge perfusion defect. Then after 12 minutes, and this particular patient got just 12 minutes of the sonothrombolysis, or the intermittent high MI impulses. You can see already there's a decrease in the perfusion defect, and this is after PCI, where a lot of times we still see a residual perfusion, microvascular perfusion defect if all they got was PCI. Here we can see almost complete resolution of the microvascular perfusion defect. See how rapidly that replenishes in there. This is an example of a patient that had the MRI done after randomizing to high MI impulses. Their epicardial vessel was open by the time they got to the cath lab, and the residual microvascular perfusion defect by MRI was confined just to this small area in the anterior wall. And infarct size, as you can see here, was significantly lower in the therapy group, the PCI plus high MI impulses group, versus just PCI or percutaneous coronary intervention alone. and EF. By 6 months, the EF was still significantly higher in the group that randomized. They were the same at the initial presentation in the ED. They got better immediately after the high MI impulse application. This was the EF right after the randomization treatment. And then at 6 months later, it was still significantly higher in the group that got high MI impulses plus PCI, okay, added to current state-of-the-art of therapy. Only 2 of the 50 patients that randomized to high MI plus PCI needed defibrillators, compared to 8 in the group that got low MI only. A 4-fold reduction in the need for defibrillators. So yeah, so cost savings in addition to that. This will be published later this month in JACC, so it's very exciting. So I think where we're going with this is, just as Steve pointed out earlier, we need to get into the ambulance, and these systems need to be portable. We're trying this with the CX50, which does have the high MI impulses with it. It's Otto Camp is spearheading that trial with a PhD that we're simultaneously supporting, that is going to take on the task of trying to there's an 8 ambulance system in Amsterdam. We're trying to get the CX50 in at least 2 of them to see if getting that treatment earlier could potentially improve that early epicardial recanalization rate and reduce the microvascular obstruction that we see. And then we're doing a post-PCI trial. Because the way we were able to at least get started with something in this country was they said, well, it's a class 1 indication to get a diagnostic echo following a myocardial infarction. So we're doing it right after the PCI. Okay, so anytime we have an anterior wall STEMI, they get PCI and an immediate echo where we apply these high MI impulses about 10 times in each view, using a full vial, in this case of Definity. And then we're looking at delayed enhancement MRI at 3 days and 6 weeks, just to see if we apply it immediately after PCI, if that has any impact. Here's an example of a patient we just did a couple weeks ago, where you can see after the PCI. In other words, the vessel's wide open with TIMI3 flow. You still see this fairly sizable microvascular perfusion defect. We'll see this in about 60 to 70% of the LAD infarcts, even after a very successful PCI. But after 20 minutes after getting the high MI impulses, you can see we were at least able in this patient to restore microvascular flow. So we'll see what that effect that has at 3 days and 6 weeks after acute anterior wall MIs. But the bottom line is these diagnostic high MI impulses that we've been talking about all day have a therapeutic effect. It's something we've had to actually go back and look to see, since we're using these every day, what are those effects? Well, at least we know on an animal-based study that there's certainly a sustained increase in NO. Now, whether that has any impact in the day in and day out running of an echo lab, we don't know. But it may. It does improve tissue blood flow in chronic ischemia. Downstream, we see this may be a very important application for peripheral vascular disease because it does cause a sustained increase in blood flow. There's a lot of ongoing therapies being tried for chronic limb ischemia. But this may be an area that could, and they're seeing a lot. I talked to, in Philadelphia, I talked to an interventionalist that is doing a lot of chronic CTO, chronic occlusions in peripheral vessels. And he says a lot of times when they do get better blood flow, it's like nothing really happens downstream. They have that same kind of microvascular obstruction problem. So he's very interested in potentially using the high MI impulses to start getting flow down there in the no reflow phenomena they're seeing in the legs. This targets delivery. This could target delivery of DNA and potentially any kind of RNA to selected sites within the myocardium. It's obviously being used outside of the myocardium in tumor therapy as well. And in acute STEMI, we see it improve microvascular flow, early epicardial patency. This all may have an impact on left ventricular recovery, which is a critical factor in preventing heart failure, preventing the need for defibrillators, and their mortality. So with that, I'll close and take any questions anybody wants or has.
Thank you very much. When did you start trying to open the arteries in the heart in animals? What year did you start?
2007, about 12 years ago. We did start in 1996. We started doing the in vitro studies, and then we started doing a canine arteriovenous occlusion model in 2001 with radiology because they were interested to see whether they could open up dialysis grafts, and it worked for that. And so the FDA actually did give us a protocol for using that in graft occlusions that a radiologist, Bill Culp, still is working on in Arkansas right now.
Now, the important thing for everybody here is we will be going to the emergency room to apply this. I mean, you presented at the ACC late breaking clinical trials. How was that received?
It was some skepticism, as well as some very large amount of, there was obviously some people saying, we've been waiting for this for a long time because, as you know, probably for at least, we've known about this microvascular obstruction post epicardial recanalization. Ito, as you know, pointed this out way back in 1997 when we were giving intracoronary bubbles yet.
Yep.
And so we've known about this problem. And there's been, I imagine, probably $1 billion NIH dollars spent on all these pharmacologic therapies that were designed to prevent this microvascular obstruction following recanalization of the vessel. Adenosine was tried, clinical trials were tried, many antiplatelet, glycoprotein 2B3A inhibitors, all were tried. None of them turned out to be successful in human trials. So this is the first one that really looks like it's had success in a human trial, now, albeit a limited trial, 100 patients. That was why there was skepticism. But we'd really like to get going with a multi-center trial to look at this because it seemed to be effective. And definitely there's a lot of animal support or basis to verify that it should be effective. What we saw in the pig atherosclerotic model seems to be matching very closely what we saw in the 100 patient model.
Tom, we're still going to be very involved. The sonographers will be very involved in this, the bubbles. It's an amazing tool that, as you say, is now therapy. And as we talked about earlier, your ejection fraction is directly predicts your outcome, your death. And if you've saved 8 to 10% of EF in these patients, they will live longer.
Yes.
From cardiovascular diseases.
Right. That's what I think we were most surprised by was the number of people that had EFs drop below 35% was significantly smaller.
Very impressive. Excellent. Well, thank you, Tom. That was really good.